Hello, everybody, and welcome to CCA's Medical Minute Podcast, sponsored by Kroger Health. Today, we're really excited to kick off a new, what I would call like a series within a series. So we do a video podcast series, and we're really excited about this new ASCO Direct. It's called ASCO Direct Patient Perspectives, kind of instigated by the gentleman to my right, to your left probably, Dr. Abdul Jazieh, who's also with us today. And we're also really excited to welcome Dr. Adjei from the Taussig Cancer Institute at Cleveland Clinic, and his reputation and his degrees precede him, but we'll talk about that a little bit more later. So anyway, Dr. Jazieh, do you want to kind of just spend a minute or two and just talk about this series and what our objectives are with that, and just ASCO in general and what the importance of that organization is?
Yeah, thank you, Steve, for having us, and thank you, Dr. Adjei, for joining us. So actually, the ASCO Direct Patient Perspective focusing on presenting the latest advances that were presented at ASCO meeting, which is usually held in the first week of June every year in Chicago. ASCO is the largest professional oncology society in the world, and they have one of the largest meeting of oncology professionals. So, for example, this year we have 5,500 abstracts submitted to the meeting. So in this series, which is ASCO accredited, approved by ASCO, we'll be inviting experts like Dr. Adjei to present to our patients' audience what is the best findings, best result that were presented in ASCO relevant to their disease, and how they can benefit from that, and what is the implication for their care. So every week we'll invite different expert to cover different diseases. So that's in brief, Steve.
Yep, that's great. Thank you. And as I've often said, patients, people don't really take a whole heck of a lot of interest in cancer until it affects them in some way. And as a patient, that's when I started to kind of pay attention to what was going on in ASCO, because you see these kind of news releases, you see things that the media pick up. And, one of the things that's not easy to tell is, does this affect me? Is this good? Is this reason for me to be hopeful? Or does this even apply to my disease? And so, Dr. Adjei, if you could talk about, I think we're going to talk about one of those today, talk about kind of in your view, what was the most important study presented at ASCO for lung cancer. And then I think we can get into who, it's not just anybody that has lung cancer, it's people that fit certain criteria. But for those people, there's lots of reasons for hope. So could you maybe kind of take us through that and explain a little bit about that?
Yes. So from my perspective, really without a doubt, the most important study that came out at this ASCO from lung cancer is, the study has an acronym, ADAURA, but simply put, it's where a certain class of patients, you have to fit certain criteria, but those who fit the criteria where the treatment comes in after they've been diagnosed and then they have surgery. As everybody knows, the whole goal of surgery is you're going to take out the cancer and hopefully cure the individual. But what we've come to understand is that cancer is very tricky, and a lot of times, by the time you find it and you do the surgery, some cells have already escaped. Some cancer cells are elsewhere in your body, and so you do the surgery, the surgeon is happy, everybody is happy, we got all of it, and then a couple of years later, the cancer shows up somewhere else. And we think it's because a few cells escaped before we caught them. And so this is a study where after surgery, patients got this new treatment. And what we found is that those who got this new treatment compared to the old treatment, which was chemo, there's a significant survival advantage. So we'll say that to put it simply, if you got this new treatment compared to the chemo, your chances of dying from the cancer is cut in half. So that's really impressive.
Yeah, very, very much so. And Dr. Jazieh, I'll toss this your way, but again, as a patient, something I've often wondered, in this particular study, what was seen was that you could have a disease-free survival benefit as well as an overall survival benefit. So when you hear of cases where something, it's like, oh, well, there's a DFS, but not an OS in this case. What's going on there? Is it that it takes longer to recur, but then it comes back in a very aggressive form? Because if the overall survival rate's about the same between treatments, what difference does it make, I guess?
Yeah. So actually, when you look at the disease-free survival, is how successful the treatment of holding the disease at bay before it comes back. But even sometimes it comes back. So the treatment may hold the disease for a while, but then it comes back, and then patients die within a short period of time. So the overall survival, which is basically how long the patients will live, it did not change. But in this particular study, this is one of the only study in this particular targeted therapy that showed that overall survival, the patients will live longer, or the chances that the patient being alive at 5 years much higher than those who did not get the treatment. So that's the overall survival actually. How many of the patients would be living for a long period of time.
And especially with a cancer that historically has not had very long survival rate. But so, Dr. Adjei, we talked a little bit before, and I had said, sometimes you hear these things and you don't know whether they apply or not. But kind of maybe another question I'd like to ask you is, who are the patients that are in that group? Is it, you hear about non-small cell lung cancer and these different things. What is this demographic that benefits from this adjuvant treatment?
Yeah, a good question. So this is number one, this is non-small cell lung cancer. But what we've come to understand is that in some cases of non-small cell lung cancer, we've been able to identify the abnormal protein that pushes the cancer to grow. And we have specific medications against those proteins. And so there's always confusion. There's the gene. The gene is what you do the testing for, but the gene produces a protein that causes the cancer to grow. And because this is targeted, so unlike chemotherapy, where we are giving it to you, and the hope is that it will kill all cells that are dividing quickly, right? So it doesn't really distinguish the cancer cell from your normal cell. That's why there are so many side effects. In this situation, we are targeting the cells that have this protein abnormality, and that happens to be that lung cancer cell, right? And so first of all, so the most important thing for everybody who's listening, if you are diagnosed with lung cancer, you have to make sure that your oncologist or primary care, whoever diagnoses you, sends your tumor off for it to be tested for this gene. Because if this abnormal gene is present in your tumor, then you are a candidate for this new drug, Tagrisso or osimertinib. And the reason this is important is that it's not a new drug. It's been approved for several years, but it was for advanced disease, those patients whose tumor has spread. So typically, oncologists were used to testing for this gene when they see you and you have stage 4 lung cancer, or your cancer has spread to other parts of the body. If they see you and you have an early stage cancer, your cancer is like 2 inches big, and there are no lymph glands in your chest that has cancer, and so you go through surgery. Typically, we didn't do the test because there was no reason to do it. But now with this study, it means that every patient with lung cancer has to get this test. Because if you are a surgical candidate and we can take out your tumor and you have this gene, you can take this drug. And if your cancer is spread and you have this gene, you can take this drug. So as it were, this is a drug that's going to help everybody, from the ones we catch early to the ones we catch late. But without this test, you can't get the drug. So it's so important.
That's fantastic. It's really, really great news. But there is a fairly small population of people for which their tumor is operable, right? In this case, I mean, it's not the majority.
Yes. So we estimate that in general about maybe 30%, or overall about 3 out of 10 patients will have the disease caught early so that it's operable. So unfortunately for the majority, it's not operable.
Okay.
Even then, there are advances going on, maybe not for this talk, some other talk we can talk about that group as well.
Is that just because as it gets larger, just there's a greater risk to the surgery?
So there are 2 reasons why your cancer may not be operable. One is technical. So that's what you're alluding to, it's too big to be taken out, or is too close to, let's say, your heart or a major organ. So you just can't safely take it out. So we didn't catch it early, right? And then there's the other group where it's more medical. So it's more like you have other diseases like kidney disease, heart disease, COPD, emphysema, and so on, so that the surgery is too risky. So you have the situations where technically you could take it out if the individual were healthy, but they are not healthy enough to go through the surgery. Then we have the ones that we didn't catch it early, it's too big to be taken out safely.
Gotcha. That makes total sense.
Yeah, but this is very important to put it in perspective. 30% of 240,000 people diagnosed in the U.S. and 2.2 million people worldwide. So it's a large number of patients will benefit from this in terms of the absolute number of people. And this is also highlight the importance of, we can cover that another time, of please, if you are smokers and you are eligible for lung cancer screening, to get screened, because catching the cancer early will make a big difference.
Okay. Yeah, that is great. That's great news. So this all sounds great. What would you see as any kind of challenges or limitations around a patient who might fit that demographic accessing this treatment?
So I think the biggest challenge is if we don't test for the mutation, right? So it's the precision oncology we are calling it now. So, if there are folks listening who know somebody who, let's say, had breast cancer, right? In breast cancer, things are so advanced that anytime the pathologist sees a breast cancer slide, you have surgery and they get it, there are certain tests they run. They look for progesterone and estrogen receptors. They look to see whether there are hormones that are driving it. In breast cancer, there's a gene called HER2. They test for that, right? So with breast, every patient with breast cancer will get their tumor tested for the hormone receptors and the HER2 gene. Unfortunately, in lung, we are not there yet, right? But we have these treatments that require that we do exactly the same as we do in breast cancer. So it's going to take advocacy from all of us, physicians, the patients, patient advocates, patient families, to really insist, so that over time, my hope is that over the next couple of years, it will be like, if it's lung cancer, just don't tell me in terms of the pathologist, just don't tell me it's lung cancer. Tell me what type it is, tell me the mutation results so that we can treat the patient. So I think right now, the biggest challenge is going to be those patients who haven't had their tumors tested.
Yep. Yeah, in fact, it's funny, it kind of ties right into another question I was going to ask you, which is what should those patients ask their oncologist? And I think so. Let's just say, for example, you're someone that's had disease for some period of time. Maybe you're only being monitored every 6 months or some interval. With what this finding is, should those patients be calling in and saying, "Hey, I don't think I've had this a test for this EGFR mutation, should I have that? I mean, so do they have to really take control of this, right?
Yeah, but the thing is that the ideal thing is really when you do the surgery and you go back for your follow-up. Normally you do your surgery a month or so later, you're going back to your follow-up. Now this is very important. Before now, it was like, well, you've gotten the surgery, we think you're a bit older, you can't tolerate the chemotherapy, so let's just watch you. So sometimes the surgeon didn't even send you to the medical oncologist to have a discussion of additional therapy because it was chemotherapy, and every doctor can tell, the patient who's strong enough to have chemotherapy or not. So sometimes they didn't even get referred. But now it's mandatory. Number one is that you have to be referred to an oncologist, and then you have to ask the oncologist whether they've done the gene test on your tumor.
Sure.
So that you are able to get this drug, because, we are talking about a cure here. We are not talking about just controlling your disease. So with this treatment, when you looked at the study over 5 years, that group, we can say that absolutely 10% of them are cured, who otherwise wouldn't be. That's comparing it to chemo. So 10% more patients with this drug in 5 years, the disease isn't back yet. And we think that from our historical perspective, 5 year survival, the chances are pretty good that you're cured, right?
Wow.
And so this is a treatment that can actually cure people. So it's really, really important. It's different from, we're just controlling the disease and buying you a few months. No, we are talking about trying to cure you. So it's important that everybody has this test.
Yeah, that's fantastic.
Yeah, just this is 10% on top of the high. So it moved the number from 78% to 88%. It's not just 10%. So but the benefit is, at 5 years is the 10% absolute number.
Yeah.
So I just don't want people to understand that it's only 10% will be alive at 5 years. No, it's actually large number.
Yeah.
But 10% of that is attributed to the addition of the drug, at least. Right,
Gotcha.
Alex?
So is that 10% compared to those who got good old chemo? It's not compared to those who got no treatment, right?
Okay.
So because the chemo also cures people, right?
Okay.
But the thing is that this is adding an additional benefit. And the more important thing, the side effects are not like chemo.
And I'll tell you, just to put things in perspective, because I want to make sure I do understand this, but are these findings compelling enough, because it sounds like it's phase 3 study at this point, are they compelling enough that it might in some cases, I don't want to say eliminate the need for it, but could you maybe not do chemo, or do you always do chemo in combination with this?
A very important question. You're very perceptive. So when the study started, we weren't sure whether this new drug was going to work or not, right? That's why you do your phase 3. So the way the study was done was that folks were supposed to finish surgery, get their chemo, and then after the chemo, they either got Tagrisso or they didn't, right? And we followed them up. But it turns out that for a number of reasons, there were a number of patients who couldn't get chemo, right? So when you look at the numbers, it's like 200 and something patients had chemo before the Tagrisso. And then like 130 folks for various reasons never got chemo. And the results are actually comparable.
Okay.
So it's suggesting that folks may actually not need the chemo, and that you could go to this directly. Now, I have to say that, and Dr. Jazieh will bear me out, this is cancer, it's tough, and we want to do all that we can. Right. So in a younger, healthy person, we will probably do the chemo and add this on, right? Because we want to pull out all the stops. But if you have an older person already with a number of health problems and so on who struggle with chemo, you can go straight to this. You don't have to give them the chemo because the data are suggesting that the benefit might actually be the same.
Okay, that's fantastic. All right, one last bonus question. If you go with this treatment, and let's just say you are a patient for which maybe you don't, chemo is not indicated, and so you've had resection, so you've had surgery, and then now you're going to go on to this treatment. What might I expect by way of side effects from that treatment? What are they seeing?
So the first thing is that you really don't have the major chemo side effects of losing your hair, throwing up, and severe fatigue and so on, right?
Yep.
The side effects, the most common side effect is actually skin rash, which is easily treatable. And apart from the skin rash, there are sort of mild side effects, not like the chemo one, right? So you might be a little bit tired. You might feel a little bit queasy. It's very, very rare. There have been a few cases where you have some heart abnormalities. Right. So a lot of times a physician will do an echocardiogram or something of your heart to make sure that everything is fine. I have to say that it's very rare, right? But it can happen. So those are the main, maybe a little bit of diarrhea. They are all sort of low level that people can live with. It's a pill that you are taking once a day, and all my patients take if they are working, they take the medication and go to work, right? Whereas, as you probably know, with chemo, a lot of folks, even if they are working, they are going to be a few days after the chemo where they have to stay at home because they are too tired and so on. So it's pretty mild that way.
Gotcha. Well, I got to tell you, this all sounds pretty good. If you're a patient that falls into that category, this certainly sounds like great news. And that's what we'll be looking for coming out of this series is, what were the findings that represent the greatest hope for people and the most actionable studies. So really exciting to have you bring this to us today, Dr. Adjei.
Thank you. My pleasure.
Thank you.
Thank you very much.
Yeah. All right. Take care. We'll see you soon.
Sure.
All right. Thanks, everyone.